Hi, my name is Brittany. I'm a first-year midwifery student, and today I will be talking to you about asthma. Here we have a patient who suffers from bronchial asthma. Her name is Sally Beagley. She is 35 years of age, is female, and is currently 26 weeks pregnant. Sally was first diagnosed with bronchial asthma when she was 6 years old. Sally has several risk factors that exacerbate her likelihood of asthma, and these include having a high body mass index of 30, which puts her in the obese category. She's a previous smoker, however, stopped immediately when she found out she was pregnant. She lives a sedentary lifestyle and does not exercise frequently, if not at all. Sally is an Aboriginal Australian and has a genetic history of asthma in her family. She also works as a receptionist at a doctor's surgery and is exposed to many sick patients. Sally is 26 weeks pregnant, and her allergic triggers are to dust mites and grass pollen. The pathophysiological changes that take place in Sally's body due to bronchial asthma result from exposure of her asthmatic triggers, being dust mites and grass pollens. When Sally is exposed to her triggers, it creates a type 1 hypersensitivity response, driven by the release of her sensitized antibodies called immunoglobulin E or IgE by plasma cells. The dust mite or grass pollen will then bind to the IgE mast cell complex, where the mast cells then degranulate and release inflammatory mediators such as histamines, prostaglandins, and leukotrienes. And these cells will contract Sally's bronchial smooth muscle in her lungs to cause airway tightening and subsequent interference with airflow. This is called bronchoconstriction as one of the main pathophysiological events that occurs within minutes to exposure. Also, because of the mediators, you will get epithelial cell inflammation of the bronchial wall/mucosa. It also helps to stimulate the parasympathetic nervous system, which then leads to a large amount of mucus production and secretion of the epithelial cells that occurs within the bronchial tubes in Sally's lungs. The bronchiole's diameter is dramatically reduced by a combination of severe bronchoconstriction, mucus plugging, and airway edema. An example of this link resulting from an asthmatic exacerbation is hypoxia, which causes a drastic increase in respiratory rate. During an acute asthma attack, severe inflammation occurs, leading to airway narrowing, excess mucus production, and bronchoconstriction. Subsequently, hypoxia develops due to impaired gas exchange. Hypoxia stimulates peripheral chemoreceptors, which in turn transmit the signal to her respiratory control center in her brain. The respiratory center increases its firing rate, leading to Sally having an enhanced respiratory rate. Preventers are extremely important when managing asthma in patients. Sally is prescribed with a preventative drug called budesonide, and its brand name being Pulmicort Turbuhaler. This specific preventer is a corticosteroid which decreases the inflammation in your lungs and helps improve airflow to make breathing easier. The mechanism of action of budesonide or Pulmicort is that it binds and activates glucocorticoid receptors in the effector cell, the bronchial cytoplasm, that allows the translocation of the budesonide GR complex in the bronchi nucleus, which binds to both HDCA2 and CBP. This budesonide CBP receptor complex prevents the production of inflammatory genes and inhibition of gene transcription that might cause bronchoconstriction, as well as the budesonide receptor complex activates the HDCA2, increasing the gene expression, which reduces the formation of cytokines such as ILs and TNF. It also inhibits the activation of the eosinophils by increasing apoptosis and suppressing the activation of the inflammatory cells, such as mast cells, neutrophils, T lymphocytes, macrophages, and dendritic cells. The overall inhibition of ILs and TNF leads to reduced airway inflammation and hyperactivity, causing inhibition of the bronchospasm, wheezing, and coughing. When Sally is in a well-controlled state, her peak flow reading is between 460 and 540 litres per minute, which is 80 to 100% of her maximum expiration rate. Sally takes Pulmicort Turbuhaler 200 micrograms as a preventer, with one inhalation morning and night. Sally's preventer before becoming pregnant that she used was a Flixotide inhaler, which is another type of preventer. However, her doctor changed it to Pulmicort as it is a Class A drug and is safer to use during pregnancy. Sally uses a reliever called salbutamol, or most people know it as Ventolin, and she requires 1 to 2 puffs as needed. Reliever medications are safe to use during pregnancy. During a flare-up, Sally's peak flow reading is between 270 and 460 litres per minute, which is 50 to 80% of her maximum expiration rate. Her triggers are dust mites and grass pollens, which are found down here. In this time, she uses Pulmicort Turbulhaler, 200 micrograms, which has an increased dosage of 2 inhalations morning and night for 5 days, then back to a well-controlled dose. Her reliever is salbutamol, and she has 2 to 3 puffs as needed. During times of a severe asthma attack, Sally's peak flow reading is lower than 270 litres per minute, which is lower than 50% of her maximum expiration rate. Her triggers are still dust mites and grass pollen. However, these would usually be found in larger numbers or more prevalent exposures. She takes Pulmicort Turbulhaler 200 micrograms with 2 inhalations morning and night for 7 days, then back to a well-controlled dose. Salbutamol is used as her reliever, and she takes 4 puffs as needed. Sally is also advised to take a drug called prednisolone, 25 milligrams, once a day to further assist with lowering and controlling her asthma symptoms. However, due to her current pregnancy, discussions need to be had with her GP to discuss whether to take it or not, and the adverse drug effects that could occur to her and her baby. Some preventative measures to help reduce the likelihood of an acute asthma attack are keeping up to date with vaccinations such as flu or COVID-19, taking allergy medications if needed, such as antihistamines, managing allergy exposure, and undertaking immunotherapy. This concludes the presentation. Thanks for listening, and I hope you enjoyed.